We're live now, ma'am. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, AMOGS Emergency Obstetrics Committee with Rajamundry, Kakinada, and Eluru societies. And today's episode is 35. It's my privilege to introduce the convener of today's webinar, Dr. Aruna Kumari ma'am. Ma'am is the senior obstetrician and consultant at Harsha Hospitals, Rajamundry, and also the president of Rajamundry OBGYN Society. I welcome you, ma'am.
Thank you, Sahati. Thank you for your warm welcome.
Yes, it's my privilege to introduce coordinator and MOC of today's webinar, Dr. Devishri ma'am. Ma'am has completed her PG in 2014 and also working as a consultant in Jaya Hospitals, Rajamundry, and currently secretary of Rajamundry OBGYN Society. I welcome you, ma'am, and I hand the session to Aruna Kumari ma'am.
Respected Sneha madam, our chief guest Kiran sir, our guest of honors Dr. Nirmala madam and Dr. Ganga Suchismita madam, Rekha madam, and all our distinguished speakers, panelists, and chairpersons, and my dear delegates. Good evening and a warm welcome to all of you for this webinar on fetal growth restriction and management of oligohydramnias. Am I audible?
Yes, madam.
Okay.
Yes, sir.
As a convener of this webinar, I'm really honored to have a distinguished personalities like Dr. Sneha madam, Dr. P.K. Saha sir, Rekha madam, Nirmala madam, and many more good speakers and experts joined us today to enhance our knowledge on FGR and oligohydramnias. As we all know, the fetal growth restriction is a critical issue in perinatal medicine, and we should try to enhance our knowledge in this critical area. So today we have Sneha madam, who is a good academician, and P.K. Saha sir, who is a good teacher, and Lakshmi madam is a good academician with us to enhance our knowledge in these topics. Today, first we have Lakshmi madam, who will share her knowledge on prediction and screening of IUGR, followed by Dr. Sneha madam, along with her group of expert panelists. She will share his wisdom on management of oligohydramnias, a seriously of life. Later on, Dr. P.K. Saha sir, who is a great teacher, will join us to share his wisdom and knowledge on managing FGR. So I also thank all our delegates who joined us today. And I request all of you to participate actively in this webinar and share all of your questions and queries in chat box. Thank you. Now, I would request Sahiti to share Madam Sneha madam's slide, CV slide. So, today, our Madam Sneha madam is the key behind this webinar. Madam is a great distinguished gynecologist and academician with 32 years of vast experience. Madam is a managing director for Sukhartha Hospital, Maternity Nursing Home and Fertility Center at Avatmal with 32 years of experience. Madam has held many leadership positions in our FOXY, like Madam is a FOXY chairperson for breast committee, and she has GCM for ICOG. And Madam is IMA Maharashtra state chairperson and MPH committee and convener for PCPNDT. Madam is AMOGS chairperson and medical disorders committee in 22 to 24. And she's AMOGS chairperson and emergency obstetrics from 24 to 26. And SAFOG working group member on breastfeeding. And Madam is a founder president for ISOPARB of Hyderabad chapter. She's a president of FIOGS in 2007 and 8. She's a founder clinical secretary of FIOGS, and she's a life member for many societies like FOXY, IMA, ISAR, etc. Madam received many awards for her service and dedication in our field, like she received Dr. S.N. Malhotra Hero National Individual Award and Outstanding Work For her outstanding work on rural obstetrics in 2008, Madam received Duru Shaha Distinguished Community Service Award in 2022, and she is a champion of Foxy Award for 2 consecutive years, and she also received Dira Award and many more awards to her crown. Madam is a good academician. She had 30 plus articles and chapters in national publications, and she has given 300 plus talks and many orations and many keynote addresses.
Thank you.
Madam is also actually involved in numerous initiatives aimed at improving maternal and child health care, like national adolescent. She is a national adolescent trainer. Madam is a national expert in UNICEF, peer reviewer in Jogi, and many, many more academic activities.
Thank you, Dr.
And
Aruna. Thank you so much.
Madam, only one point, madam. Madam is going to contest for vice president post this year. Such a great leader and academician with a great vision. She is the best deserving candidate for vice president. So I request you all to support her. Thank you, madam. Now the field is yours, madam.
Thank you so much. Thank you so much, Dr. Runa. In fact, indeed, it is my pleasure to be, with all of you. A very good evening to all of you. My respect and regards to all the seniors here, especially Dr. Kiran Kurtakati, our AMOGS president, and of course, guest of honor for today's program, Madam B. Nirmala, and of course, Madam Ganga Suchi Smriti. And the seniors here we have as chairpersons, Dr. Narsamani Shankara, Dr. Amulya Irgineni as chairperson, and Dr. Satyanarayana and Dr. Aruna Kumari herself as chairperson. We have a very distinguished speaker, Dr. P.K. Shah, who is also the past president of Foxy, past president of IAG, past president of even, he's the dean of the College of Ultrasound. So such an illustrious personality with highly decorated CV and a very good revered teacher, I would say, as Dr. Aruna Kumari is introduced. It's our pride to have him, and of course, Dr. Inki Lakshmi as a speaker who will be speaking on the prediction and screening of the FGR, and Sir will be speaking on the management of FGR. The panel discussion is actually just a revision of that, because it is, but I have covered it as, the spectrum of disorders for amniotic fluid. It may be oligohydramnios to polyhydramnios, and then how do you manage it practically? So that is why it's a practical case-based discussion, which I'm sure all of you will enjoy it. I have made it very simple so that all of you can participate, and it's going to help you in long-term practice. So with this brief preamble, I would like to go ahead and thank all of you once again. And once again, I hand over to Dr. Aruna Kumari and Dr. Devishri for taking this program ahead, and invite the guest of honor for their precious words. Thank you so much for joining.
Thank you, madam. I would take the honor of inviting our guest of honor, Dr. Nirmala Devi, madam. She's our president of APOGS, that is our Andhra Pradesh State Committee. Madam runs Sri Kanaka Mahalakshmi Hospital in Eluru, and she is the present president of Eluru Obstetrics and Gynecological Society, and she is the organizing chairperson for APOG 2024. Apart from this academical activity, madam is a very, very active Rotarian. She received many awards, like Excellence Award in 2007 by Healthcare International Hyderabad, and Visishta Seva Puraskar Award in 2007 by X-Ray Organization, and Glory of India Award in New Delhi, and Champion President Award by Rotary Districts 2030-20 in year of 2014 and 15, and many, many more awards as a Rotarian. Her special interests are social service, music, and singing. Welcome, Madam Nirmala, madam. Please give your message, madam.
Good evening. Good evening, all. First of all, I congratulate AMOGS for conducting the webinar involving the societies of only Andhra Pradesh. I thank Dr. Sneha Bhuye, chairperson AMOGS, to have taken up very important topic of fetal growth restriction and amniotic fluid. This webinar is involving very good speakers like Dr. P.K. Shah, past president, FOGSI, IAGE, IFUMB, MOGS, AFTT, and panel moderator Dr. Sneha Bhuyer, expert Dr. Rekha Rajendra Kumar, and many more participants. The webinars like these will be useful for brushing up latest developments in the particular arena, either in diagnostics or management, with more clarity and confidence. Involving few societies like 4 and giving opportunity to young specialists boost their participation and presentation skills at large. I thank Dr. Sneha Bhuyer for taking up this webinar involving only AP societies and especially congratulate the convener, Dr. Aruna Kumari, President Rajamundry OBGY Society, Coordinator and MOC, Dr. Devishri, and all other participants of the webinar. I thank Dr. Sneha Bhuyer, Dr. Aruna Kumari, and all the faculty as a whole for inviting me for this occasion. I thank Dr. Kiran Kukoti, President AMOGS, who graced this webinar as chief guest. I wish Dr. Sneha Bhuyer and as Vice President contestant all success in her future endeavors. Thank you once again for inviting me for this webinar. Thank you.
Thank you so much, madam. Thank you for your wishes and, of course, the wholehearted support. Thank you so much.
Thank you, madam. Thank you for your kind message. Now, I take the honor of inviting Dr. Ganga Suchismita, madam, who is the senior most obstetrician of our society, and she is a past president of our Andhra Pradesh chapter, AMOGS. And madam is a great academician, and she is the cornerstone of starting our Rajamundry Society. Madam did her MBBS and DGO from Andhra Medical College, Vizag, and she did her DNB from CMC Eluru, and she is a University Gold Medal during her undergraduate in OBG. And Madam is practicing in Rajamundry at Bharadwaja Hospitals. And Madam is a great practitioner of heartful meditation also, and she is a good advisor for all of us in all times of need. Thank you, Madam. Thank you for accepting the invitation. And please give us a short message.
Thank you, Aruna. Thank you so much for making me participate in this meeting. It's a great honor to be here with you all. With so many people ready to talk and give out their messages, I think it will be very irksome on my part to talk a lot. So let me conclude. Let me convey my regards to Dr. Sneha and all the best to Dr. Sneha. Thank you, Madam Nirmala Garu. And thank you, Aruna, and all the faculty. I wish you all the best. And we are just eagerly waiting for your expert opinions and latest modes of treatment, which give us confidence. Again, I wish you all the best. Thank you very much, Madam.
Thank you, madam. Thank you so much for all your wishes and, of course, all your blessings and support. Thank you so much, both of you, Madam Nirmala Devi and Dr. Ganga Suchismati, for joining and blessing all of us. Your precious words mean a lot. First, with this, I thank all the esteemed faculty and, of course, our convener and coordinator. And I hand over the session to Dr. Aruna Kumari and Dr. Devishri for the academic sessions. Thank you so much.
Thank you, Madam. Thank you so much. Now I request our coordinator, Dr. Devishri, to proceed to conduct the proceedings. Devishri.
Thank you, ma'am. Aruna, ma'am. Good evening to all the delegates over here. And now we will start the session. Our first topic is prediction and screening for fetal growth restriction. Speaker, Dr. I. Lakshmi, past President Bhimavaram. First of all, I would like to invite our chairperson, Dr. Narsavani, ma'am. Ma'am is a vice president of Bhimavaram OBGY Society. Ma'am is a consultant at SVR Maternity Hospitals, Bhimavaram, with an experience of 24 years in the OBGY practice. And her areas of interest are high-risk pregnancy, PIH, and ectopic pregnancy. We welcome you, ma'am, Narsavani, ma'am. And I would like to introduce our second chairperson, Dr. Amulya, done her MBBS from Eluru Sitaramaraju Academy of Medical Sciences, MS OBG from the same medical college, fellowship in minimal access surgery and ART at Gurgaon, worked as SR in Ashram Medical College, previously worked at Government Hospital Khammam, and now she is currently a consultant at OBGY at Amulya Hospital, Eluru. I welcome both the chairpersons, and I would like to hand over. I request our chairpersons to kindly introduce Dr. I. Lakshmi, ma'am.
Good evening, all. I am Dr. Naswani. At the outset, I should thank Dr. Sneha, ma'am, and also Dr. Aruna and Devisri, who are other dignitaries who try to bring this scientific session in today's scientific session. And coming to the topic of the fetal growth restriction, and that is the topic which is very varying to every obstetrician, even with the advent of all the advanced gadgets like Doppler studies. Still, we are in the varying of the adding up the prematurity and stillbirth. So it is very difficult to take a decision of the obstetrician. So the advent of the so many modalities like predictors, soft markers, and screening by ultrasonography, all these things, we can assess how far these modalities will help us in deciding the and in diagnosing the patient and also dealing with the cases and how far they help us. That is all dealt by our speaker, Dr. Irinki Lakshmi. And Irinki Lakshmi is a consultant at Lakshmi Hospitals, Bhimavaram, and she is the founder president of Bhimavaram OBGY Society. And she has done MD at National Institute of Pondicherry. And she has participated in so many national and international conferences as a faculty. And she received Best Poster Award in World Congress in 2002 at Mumbai. And she has MRCOG Part 3 examiner. And she has 20 years experience of obstetrics and gynec and urogynec. And she well versed with the techniques of non-descent vaginal hysterectomy and minimal access surgery. And she is the recipient of a prestigious Icon Healthcare Award of 2024 by Times of India. Now I welcome Dr. I. Lakshmi to proceed with her talk.
Thank you, Madam, for the kind words of introduction. At the outset, I want to thank Dr. Sneha, Madam, and Dr. Aruna, Madam, for giving me this opportunity. And I also wish Rekha, Madam, and Sneha, Madam, and all the very best for the election, upcoming election. Thank you. Can I share the slide?
Yes, sir. Sure.
Thank you, Dr. Lakshmi. Thank you so much. All the best.
Sahiti, yeah, I think that's fine. Yeah. Yeah, that's perfect. We can see.
Sound. Prediction and screening of FGR. Growth of a fetus is determined by its genetic growth potential and influenced by maternal, fetal, and placental factors. Failure of this mechanism leads to fetal growth restriction. The overall incidence is 3 to 10%. So why is it important to identify FGR? If it is not recognized, it can result in poor perinatal outcome. Fetal asphyxia has been identified in 50% of the FGR babies. 20% of them can be stillborn, and it is an important cause for perinatal mortality. Not only that, it also has long-term neurological sequelae. So, a hypothesis was put forward by the British epidemiologist David Barker, who said that intrauterine deficiency followed by postnatal abundance can result in metabolic syndrome. This theory was based on the observation of increasing tendency of IUGR in preterm babies developing diabetes, hypertension, and cardiac disease in middle age. There is a lot of confusion regarding the definition of FGR. ACOG says that small to gestation age babies are newborns with birth weight less than 10 centile, whereas FGR is fetal weight less than 10 centile for gestation age.
RCOG defines FGA as fetal size less than 10 centiles, but if it is associated with Doppler changes, it is FGR. So inputs were taken from all these societies and a consensus was arrived at, which is called the Delphi consensus. So they categorized FGR as early and late. If the FGR sets in before 32 weeks, it is early, and after it is late FGR. So at any point, if the estimated fetal weight or the abdominal circumference is less than 3rd centile, it is classified as FGR. But if it is between 3rd to 10th centile, in early FGR, if it is associated with abnormal Doppler findings like uterine artery pulsatility index more than 95th centile or umbilical artery pulsatility index more than 95th centile, it is FGR. In case of late FGR, 2 of the 3 factors, that is the weight being less than 10 centiles, or if there is a drop in weight by 50 centiles in the growth chart, or the presence of umbilical artery pulsatility index more than 95th centile or CPR less than 5th centile. So this is the definition of FGR by Delphi consensus. So the early onset FGR, the causes could be chromosomal abnormalities, intrauterine infections, but as much as 50% is due to early onset preeclampsia. Late onset FGR develops after 32 weeks and the cause is uteroplacental insufficiency. Late onset is the most predominant. The prevalence is almost 70%. The babies are asymmetric in appearance because of the head sparing effect. And early onset FGR is associated with a spectrum of Doppler alteration starting from uterine artery, umbilical artery, middle cerebral artery. Whereas late onset, the predominantly changes are seen in the cerebral blood flow. The perinatal mortality of the early onset is very high. Also, maternal complications are profound in case of early onset because 50% is due to early onset preeclampsia. But the main clinical challenge in early onset is management, because even if you diagnose FGR, you have hardly much to offer in terms of treatment. Whereas late onset, the problem is with detection. Since it starts after 32 weeks, there is a high likelihood of missing the diagnosis. So in the evaluation of FGR, first you have to predict IUGR and stratify the risk. This is followed by screening tests to confirm IUGR. Then you have to subject them to surveillance and management. So the risk assessment is a dynamic process with continual assessment from first visit and throughout pregnancy. So different factors are taken into consideration: preconception BMI, associated medical disorders, past obstetric history, and in the present pregnancy, clinical examination findings and history. And in investigation, the biochemical markers and ultrasound biometry and Doppler are taken into consideration. Based on these risk factors, the women can be classified as low risk, means there are no risk factors. Moderate risk based on history and current pregnancy findings, and high risk. Most of the high-risk women have medical disorders like chronic kidney disease, hypertension, SLE, complex cardiac disease, etc. So just to recap some of the important risk factors, complex cardiac disease, especially with ventricular dysfunction, is defined as a moderate risk factor. And gastric bypass surgery is a moderate risk factor, but not gastric banding. Smoking has an increased risk of SGA, especially in the older women. Suppose a woman stops smoking by 15 weeks, the risk can be nullified. So e-cigarettes are less dangerous compared to the conventional cigarettes, and NRT is relatively safer. So the association with well-controlled asthma, anemia, and inflammatory bowel disease and depression is negligible if it is well controlled. Significant antepartum hemorrhage has been classified as a high risk. What is significant antepartum hemorrhage? That which requires hospitalization or there are repeated episodes of bleeding. Placenta previa without bleeding is not a risk factor. So age more than 40 or BMI less than 18.5 or poor weight gain during pregnancy, all these have been identified as moderate risk factors. So that is the reason why women should be offered height and weight measurement and BMI calculation at booking. Isolated single umbilical artery increases the SGA risk by 3-fold. Echogenic bowel is a risk factor, but RCT found this association to be stronger only if the babies were stillborn. However, it is classified as a high risk factor. So findings that mid-trimester anomaly scan should be incorporated in the FGR risk assessment and screening planned accordingly. So the genetic abnormalities that were associated with FGR were aneuploidy, single gene mutations, partial deletions, ring chromosomes, and genetic imprinting disturbance. So 50% of trisomies 18 and 13 develop FGR. Evidence of FGR before 20 weeks is suggestive of aneuploidy, so this will warrant an invasive testing, that is karyotyping and microarray. So this is the chart which was put forward by ASUOG in 2024. You can see the risk groups as low risk, moderate, and high risk, and the corresponding screening tools are based on the risk stratification. Even the surveillance is based on this risk stratification. Screening for STR is based on the risk category. First step in screening is to establish the correct gestational age. The routinely used calculation of LMT is not reliable. All pregnancies should be dated by ultrasound, as recommended by the NICE guidelines. So the other tools are symphyso-fundal height growth charts and ultrasound, biometry and Doppler, and biochemical markers. So you can see from the chart that low-risk women, that is with no risk factors, after the anomaly scan, they should be offered only symphyso-fundal height measurement. Ultrasound is not offered. Women with moderate risk factor, they should be offered serial ultrasound surveillance from 32 weeks every 4 weeks, that is biometry and Doppler. Suppose the woman belongs to the high-risk group. Uterine artery Doppler should be done between 20 to 24 weeks. And based on this, you have to offer the investigation. So normal uterine Doppler with estimated fetal weight more than 10 centiles, they should be offered serial ultrasound surveillance from 32 weeks onwards, every 2 to 4 weeks. Normal uterine artery Doppler, but the estimated fetal weight is less than 10 centiles. That means it's an SGA baby. They are offered ultrasound screening from 28 weeks, every 2 weeks. If the uterine artery Doppler is abnormal, but weight is more than 10 centiles, again, they are also offered the surveillance from 28 weeks, once in 2 to 4 weeks. If the uterine artery Doppler is abnormal and also the estimated fetal weight is less than 10 centiles, that means it is already FGR. So you have to discuss with the fetal medicine specialist and start your surveillance. So that will be covered by birth. So small for gestational age baby, 3 weeks growth monitoring and 2 weekly umbilical artery and MCA artery Doppler should be performed. There is another group of women who, though they belong to the low risk, they cannot be offered symphyso-fundal height measurement as the screening tool because of obesity, fibrosis, and uterine malformations or abnormal leg. So those women, they should undergo ultrasound surveillance from 32 weeks onwards. And for congenital uterine malformations, you can start the surveillance at 28 weeks. So symphyso-fundal height is a universal screening tool and offered to all the low-risk women to assess the fetal growth. It increases by 1 centimeter per week between 14 to 36 weeks. The sensitivity is variable because of the confounding factors like obesity, full bladder, amount of lighter, all this will change the symphyso-fundal height measurement. So suspect FGR, there is a difference of more than 3 centimeters between expected and observed values. So this is how you measure the symphyso-fundal height by an inch tape from the symphysis pubis to the fundus. So this is one such chart. So here along the x-axis you have the gestation age and along the y-axis the symphyso-fundal height in centimeters. So ultrasound, it is an important and useful tool not only for screening, also for confirming the diagnosis of FGR. So fetal biometry and fetal Doppler are what we evaluate by ultrasound. So fetal biometry means you monitor the growth with BPD, head circumference, abdominal circumference, and femur length. These are the parameters which actually can be used to calculate the fetal weight as well. So BPD and head circumference are usually tools for calculating gestational age and not growth, because BPD accuracy is affected by alteration in the head shape. And head circumference is a better tool than BPD in predicting FGR as it is not subjected to variability. Head circumference not reliable as a single tool, but it is incorporated in the Hadlock's formula along with abdominal circumference and femur length measurement. This is why the head circumference is not as reliable as a single tool, is because of the brain being the last organ to be affected by FGR. Abdominal circumference is the most accurate single parameter and it is reduced in FGR because of decrease in liver size, glycogen storage, and abdominal fat. Less than 1 centimeter increase in fetal abdominal circumference in 14 days has a sensitivity of 84%. Sensitivity can be enhanced by serial measurement. So to optimize accuracy of measurement, You have to measure it along the transverse action at the level of bifurcation of portal vein. Stomach bubble should be seen, but the kidney should not be visualized, and abdomen should occupy more than half of the total image. So the most accurate parameter for establishing diagnosis of FGR is estimated fetal weight calculation by Hadlock's formula. So use the abdominal circumference, head circumference, and femur length in this calculation. PPT is not included. So fetal growth charts are available. WHO fetal chart, it is a country-specific customized chart, whereas the intergrowth charts are universal charts. The customized charts are preferred based on the premise that fetal growth varies across countries and ethnicities, so each country should have its own chart. So this is one such chart where gestation age is depicted along the x-axis and weight in grams along the y-axis. So this is the 95th centile graph, and this is the 5th centile. Above this will be large for gestation babies, and below this will be small for gestation. And from this chart, when you serially plot, you can also see if there is any drop in weight by 50 centiles. So if it is more than 50 centiles, there is drop. It is suggestive of late FGR. Doppler is not only a tool for diagnosis, but also for surveillance. The various indices that are measured are SG ratio, pulsatility index, and resistance index. Pulsatility index is what we commonly use for defining FGR. So arteries studied, uterine arteries, umbilical artery, and middle cerebral arteries are used for screening. Normal pregnancy is characterized by low resistance blood flow system, enabling transplacental transfer of nutrients and gases exchange. So increase in resistance to blood flow in the uterine arteries followed by umbilical arteries will result in deficient blood supply to fetus. This triggers a protective mechanism, and that is called the brain sparing effect. Blood circulation is diverted from other organs to the brain. So this is reflected in the middle cerebral artery as low resistance flow. Changes that can happen in the Doppler. So this is the first normal umbilical artery, which is a low resistance flow. As there is high resistance, there is fall in the diastolic. At one point, it disappears and it also gets reversed. So as the resistance of the umbilical artery, the compensatory mechanism being triggered, and it results in high resistance middle cerebral artery being converted into a low resistance flow system. So uterine artery Doppler is usually measured between 11 to 14 weeks as a part of the first trimester screening, extended first trimester screening. And for women with high risk, it is to be repeated at 20 to 24 weeks. So uterine artery pulsatility index more than 95th percentile with small for gestation age baby is diagnostic of early onset FGR. Presence of unilateral or bilateral diastolic notching indicates risk for uteroplacental insufficiency and preeclampsia. So uterine artery Doppler abnormality alone in a low-risk women is not significant, but useful if it is incorporated with first trimester screening algorithms and combined with maternal risk factors and biomarkers. So this is the screen cutoff values. So here you can see that if there is adequate trophoblastic invasion, it is a low resistance flow system. But if the trophoblastic invasion is inadequate, the resistance is also not changed. So umbilical artery is the next artery which is studied for screening. So as the feto-placental perfusion deteriorates, it is reflected in the umbilical artery Doppler as well. So the characteristic changes are increase in pulsatility index and resistance index, followed by decrease in the diastolic flow. Initially, there is absence of end-diastolic flow followed by reversal of flow. Absent end-diastolic flow is diagnostic of early FGR, even if weight or abdominal circumference of the fetus is normal, according to the Delphi concept. So these are the screen cutoffs. So here, it is a low resistance umbilical artery flow, which actually gradually there is increase in resistance, absence of diastolic flow, and reversal of flow. Middle cerebral artery is another important tool for screening. Cerebral CP ratio is more important than MCA. CPR is nothing but pulsatility index of middle cerebral artery by pulsatility index of umbilical artery. So if it is less than 5th centile, it is used to diagnose late FGR. The MCA PI cutoff is 1. Similarly, CP ratio cutoff is also 1. So here you can see a high resistance middle cerebral artery flow system is getting converted into a low resistance system, and this is similar to the normal umbilical artery flow. So ductal stenosis is not used as a screening tool. So biomarkers, low PAPA, high alpha fetoprotein and high inhibin are associated with increased risk of SGA or SGR. Placental biomarkers are associated with adverse outcomes. So once you find these placental markers to be biomarkers to be abnormal, the surveillance, ultrasound surveillance should be increased. So biomarkers combined with ultrasound increases the accuracy when compared to markers alone. So to summarize, 20% of the FGR babies can be stillborn, and it is the second important cause for perinatal mortality. 50% of FGR babies can develop intrapartum asphyxia. And the risk assessment for FGR is dynamic. It is started at booking visit and continues throughout pregnancy. The classification of early and late FGR is useful as the causes, surveillance, and prognosis are different. The evaluation of FGR should include determining the exact gestation age, recognizing the small baby, and establishing the diagnosis of FGR based on Delphi countries. The universal screening tool, SFH measurement, is offered to low-risk women, and all high-risk women should have ultrasound screening for FGR. Karyotyping and microarray are additional tests offered to women with early onset FGR less than 24 weeks. So finding the signs of FGR is a game of hide and seek. The ultimate puzzle is to get the missing growth pieces. Thank you.
Thank you, Lakshmi ma'am. I request the chairpersons to please kindly comment on the topic. Dr. Narsawani ma'am and Dr. Amulya.
Madam needs to unmute, please. Unmute yourself. Narsawani madam, please unmute yourself.
So there is a question in the chat box. Somebody has asked at what gestation age biochemical markers are done. It is actually the biochemical markers are combined with the first trimester screening. So between 11 to 13 weeks. So that is called the extended first trimester screening, along with some ultrasound mark.
Yeah, it's the PAPA for first trimester and even the maternal serum alpha fetoproteins for the second trimester.
Hello. Hello.
Yes, yes, you can speak now.
Lakshmi, it's an excellent presentation. So, will you elaborate on PAPA? Is it very useful or to some extent the biochemical findings?
No, the biochemical markers alone are not predictive of anything, but they should be, as I already mentioned, it should be incorporated with the algorithm of first trimester screening. And ultrasound findings and the risk stratification, all that should be taken into consideration. It is not only as of now, biochemical markers alone cannot be taken as, but it increases the risk actually. And as I already mentioned in the first slide, positive biochemical marker will stratify the risk as high risk. So all the surveillance, all the screening should be applied to this group as high risk. That is all. It will not confirm or it will not categorize the IUGR based on this.
Will you add anything on amniotic fluid?
Amniotic fluid, I don't think it is of any significance right now.
Okay, thank you. Thank you.
Thank you.
Dr. Lakshmi, can you tell what is the incidence of IUGR in patients with single umbilical artery?
With single umbilical artery, it is almost threefold increase in IUGR risk is there, sir, and it is a high risk for FGR.
Okay. Thank you.
Thank you, sir.
What is the most important investigation to predict late IUGR?
It is CPR, madam. It is the cerebroplacental ratio, the pulsatility index of middle cerebral artery by the pulsatility index of umbilical artery. The cutoff is 1.
What is the role of sildenafil in the treatment?
It is actually they concluded in the randomized control study. I think that it has no role. Sir will be enlightening us about the management and what are the different treatment protocols that can be offered. But as far as I know, it has no role.
Any more questions? Thank you, Lakshmi ma'am. And it was a very wonderful topic. And you have put everything in a very brief. Your slides are very good. And thank you, ma'am.
Thank you.
Now we would proceed with the panel discussion. Sahiti, can you please share the panelist CV slides?
Yes, ma'am.
Today's topic for panel discussion is amniotic fluid, the sea of life. And we have Dr. Sneha Bhimavaram ma'am as our moderator and Dr. Rekha Rajendra Kumar ma'am as our Dr. Rekha Rajendra Kumar ma'am, practicing for the past 33 years. Ma'am is a president for Bangalore Society of OBGYN 2024 and 25. Ma'am is a lifetime. Ma'am has taken Lifetime Achievement Award by Foxy 2025. 7th rank of Bangalore University MBBS examination, All India topper ICOG reproductive medicine examination, invited faculty in more than 1,000 state, national and international conferences. Ma'am is an organizing chairperson of FemPower National Conference. Ma'am worked as a chairperson, Ethics and Medical Legal Committee, Karnataka State OBGY 2023 to 2025. She is also a South Zone Coordinator for Foxy Medical Disorders in Pregnancy Committee 2024-25. And ma'am is a EC member at Karnataka branch of Indian Society of Assisted Reproduction. She is a chairperson, Infertility and ART Committee, South Zone Coordinator, Foxy Infertility Committee, founder EC member, Karnataka branch of Indian Fertility Society. She is a life member of 10 prestigious societies. She is a peer reviewer of Jogi, past member of Foxy Sexual Medicine Committee, Endocrinology Committee, Food and Drug Committee. She is also a joint organizing secretary of Abhignan 2021. She received 21 awards and 25 felicitations, including 1 international, 3 state, and 2 Foxy awards. She is also a ex-PG teacher of MS Ramaya Medical College and Bangalore Baptist Hospital. She has published 28 original articles and 1 case report, 1 poster presentation in Eshere Europe Conference 2021. And she also had more than 100 radio and television talks, 100 camps, and many more. We welcome you, ma'am. I would like to introduce our first panelist, Dr. Fani Kumari, ma'am. She's a consultant at Sri Nanda Hospitals, Rajamundry. Our second panelist, Dr. Shravani, consultant from Kakinada. Our third panelist, Dr. A. Ganga Bhavani, ma'am. She's a consultant at Ratna Maternity and Child Hospital, Rajamundry. Our fourth panelist, Dr. Lakshmi Kiran, Associate Professor, Rangaraya Medical College, Kakinada, Vice President, Foxy, Kakinada. Ma'am is also a past chairperson, APCOG 2019, panelist and chairperson, APCOG 2023. She also presented many papers. She's also currently working as Secretary, Foxy, Kakinada. Ma'am also published papers in national and international journals. She also won the Best Doctor Award. And our next panelist, Dr. Nirupama. She's a consultant, Sri Gautami Nursing Home, Bhimavaram. The other panelist, Dr. Ramya, done her MBBS from Ashram Medical College, MS from Mamta Medical College, Khammam. Previously worked at Manipal Hospitals, Bangalore. Worked as an assistant professor at KIMS Hospital, Samalapuram. Currently working as consultant OBY at Ayush Hospitals, Eluru. Her areas of interest are high-risk pregnancy, infertility, laparoscopic surgery. Our next panelist, Dr. Anjani, done her fellow in reproductive medicine from SRMC, Chennai, done her MS OBG from Gulbarga, done her MBBS from Gannavaram Medical College, Pinamne Siddhartha Medical College, currently working as assistant professor in Ashram Medical College, chief consultant at Anjani Dasarath Hospitals. Her areas of interest are infertility and high-risk OBGYN. She also presented papers and delivered many talks. Other panelist, Dr. P. Nagaveni Prapurna, She's a MS, DNB, FNB, Reproductive Medicine, FMAS, consulted at SVR Maternity Hospitals, Bhimavaram. FNB, Reproductive Medicine at Milan Fertility and Birthing Center, Bangalore. Advanced Diploma in ART and Reproductive Medicine, Kiel University, Germany. Then her MS from GSL Medical College, Rajamundry. MBBS from Andhra Medical College, Visakhapatnam. She's a member of FOXI, ISAR, IFS, and AMASI. Presented papers in national and state conferences.
Yes, thank you so much, Dr. Devishri, for the the coordination for this program, and thank you for the introduction of the panelists. So let me just share my screen, and I hope you can see that. Actually, today's panel discussion, this topic, I have taken it a little different, from the routine. And because, all the time we think that all the FGR and oligohydramnios go hand in hand. So many of the times they can be a coexisting condition, but many of the times it may not correlate with the clinical condition as well. The management will solely depends upon the etiology and how the prognosis of the pregnancy will be. So right from early first trimester, what are the situations where you find the different, variations in the quantity of the amniotic fluid? So once again, I welcome all of you, Dr. Rekha as panelists and all the other panelists. I would just like to make this discussion little interesting. These are the facts which actually all of us have learned as UG and PG. But just to revise it, Dr. Shravani, I would like to know from you why amniotic fluid is called the sea of life. I mean, why is it so important that we are talking about the amniotic fluid? Do we have Dr. Shravani here? Oh, then I think anybody can take up this topic. It's the question. Yeah. I would request the panelists to please unmute yourself and check whether you can speak. Please unmute. Please unmute. Do we have Dr. Shravani? Because I think I can see somebody driving, so we should not disturb her, in fact. Okay. Okay.
And those who have not named themselves, please name yourself so that we can find out.
Yeah, so we start with the other panelists. Should we go ahead with Dr. Lakshmi Kiran, Dr. Prapurna, Dr. Fani Kumari? Yes. Please unmute yourself, all of you. I think we have to go ahead fast. We have only 40 minutes and we have to go ahead fast. Why amniotic fluid is so important? Why is it called as sea of life?
Lakshmi Kiran, madam, you can speak.
Yes, ma'am. The amniotic fluid is very important for the life of the fetus, madam. If amniotic fluid is very, very less, there may be chances of IUCR and complications to the baby. IUFD can also be there. And also preterm labor also is one of the complications. If it is so, polyhydramnios, then chances of cord prolapse and also maternal complications like diabetes and hypertension also be there, ma'am.
Okay. Anything else anybody wants to add? Madam Fani, can you please unmute yourself? Please unmute. Yes.
I'm Bhavani. Am I audible, madam?
Yes, now you are. All of you, please unmute yourself, because in time you are not able to. Please unmute yourself. All of
Dr.
you.
Fani,
Sanjani as well. Please unmute. Yes. Yes, Dr.
Amniotic, shall I tell, madam?
Yes, please.
Amniotic fluid surrounds the baby all around. It acts as a cushion. It protects the baby from external heat, stroke, acts as a shock absorbent. It protects the umbilical cord and in turn baby circulation.
Right.
Amniotic membranes covering the amniotic fluid protects the baby from infection. And fetus receives some nutrition like albumin and lecithin.
Right.
It acts as a soothing sound of low frequency white noise, which helps develop hearing and strong bond with parents as well.
Yeah.
Amniotic fluid lies in between the baby and maternal uterus and thereby acts as a direct link between the two. So transfers the mother's moms directly to baby whose thermal control is immature.
Right.
Thus, the amniotic fluid is called sea of life.
Yeah, so it's not only the nutrition and the maintenance of temperature, but also it is the shock absorbent as well. So as you have already said, whether because if the quantity is less, still that pregnancy carries a problem. And if the quantity is more, even then the pregnancy carries a risk. So Madam, I think Fani Kumari, we can go ahead with the next panelist. Madam, can you please unmute yourself? I think Sahiti, she's facing some problem to unmute. Can you please unmute yourself?
Already Dr. Panikumari ma'am was informed, ma'am. Ma'am is trying to unmute.
I am Dr. Bhavani, madam.
Yeah.
Yeah, others can answer. No?
Okay. Please go ahead. We have 5 more panelists. We can take up. Please go ahead.
Hello.
Yes. Quick. All of us. Okay. I only call. Dr. Lakshmi Kiran.
Yes, ma'am.
What are the constituents of the amniotic fluid? What does it contain?
Actually, it's most of the urine of the baby and also pulmonary lung secretions and also small quantity from the placenta, vascularity from the placenta, and some solvents like albumin and minerals.
Right.
It has that, ma'am.
Okay, so initially it's only watery, but then as the baby swallows the fluid and then it passes through the gut and it is excreted also. So later on it becomes little cloudy, right? So I think we can have Dr. Lakshmi.
To the extent of 90% is water only.
Yes.
Yeah, Dr. Lakshmi, please go ahead.
Can you please
Am I audible now?
Yeah, all of them to please unmute themselves. Please speak. Prapurna. Dr.
Yes,
Prapurna, you can take up. What is the normal AFI? When do you call it as low? When do you call it as high? How do you calculate it?
Ma'am, AFI is calculated from using the ultrasound. It can be calculated by 2 methods, either by mean vertical pocket or by amniotic fluid index.
Okay.
In the mean vertical pocket, we'll be taking the largest pocket, which is seen in the vertical pocket, seen in the ultrasound, devoid of any fetal parts or umbilical loops, and we'll be measuring the size.
Right.
So less than.
For AFI.
Hello.
Yes. Go ahead.
Yeah.
Than 2 centimeters is defined as oligo, ma'am, whereas greater than 8 centimeters is defined as polyhydramnios.
Okay. How do you calculate AFI 4-quadrant method?
Usually AFI is calculated in the 4 quadrants method after 20 weeks of gestation, when the uterus reaches above the height of umbilicus. Here we based on the linea nigra, we'll divide the uterus into 4 quadrants, and each quadrant will be taking the measurement. We should be taking the measurement perpendicular to the abdomen. So in that we'll be calculating.
Yes.
And that also we will be doing without devoid of the fetal parts and loops, ma'am.
Yeah.
And umbilical cord.
Okay. So,
yes.
Madam Fani Kumari, what is the normal AFI?
Normal AFI is 8 to 18, madam. And if it is less than 5, it will be called as oligomnias. And if it is more than 25, it will be called as we'll consider it as polyhydramnios.
Correct. So that is how we come to the first case now. We go ahead with the discussion from you only. Madam Fani Kumari, we have this primary gravida with 2 months. See why I have taken these cases, because they are clinically, you are facing these cases day in and day out. So we just want you to share your experiences and whether we can come to any conclusion. We have this primary gravida 2 months pregnancy she's asymptomatic and she comes to you for routine antenatal care. So her baseline scan shows intrauterine pregnancy of 8 weeks with cardiac activities plus present, but the size of the sac is less and amniotic fluid is less. The fluid at this point of time is less. So what are the likely causes for this, and how would you, explain the relatives about this pregnancy outcome? How would you manage this pregnancy?
Commonest causes are severe form of dehydration and altered glucose tolerance or otherwise diabetes mellitus, Kepler syndrome or preeclampsia and hypoxia and chromosomal abnormalities.
Okay. So how do you counsel the patients and relatives at this point of time that the sac size is small, the fluid is less?
First of all, we'll go through some of the investigations like oral glucose tolerance test and baseline ultrasound and follow-up after 2 weeks again. And double marker screening test.
Okay.
And screening for preeclampsia.
Okay. So for this patient, suppose everything was done. When you called her for follow-up after 2 weeks, you find that, the sac size is small, the fluid is less, and fetal cardiac activity is absent. But then you had not counseled the patient because you were just told that you have to come up for follow-up after 2 weeks. Then now how to counsel this patient and relatives? It's embryonic demise now.
Yes.
How do you counsel? I think anybody can take up. Next question to Dr. Lakshmi, Dr. Prapurna. Yes.
Ma'am, in this case, in the first ultrasound only, we'll tell the patient, should inform the patients.
Yes.
In first trimester, if you see this kind of a picture, that might be of genetic cause, or it might be due to chromosome, like congenital anomaly of the baby,
right,
and all other factors. We have investigated accordingly that found there is no other reason to it, like impaired glucose tolerance or hypertension or anything. So we'll say that in the first trimester, due to the
immediately after the first ultrasound, you must inform the patient and
we will say that it will be likely, yes.
Yes. Okay.
It will be likely going to fetal demise because this much of low liker, it will not continue.
Yeah, I would say to be guarded, it can go to either side, right? Do we have Dr. Nirupama here?
Dr. Sneha, can I just add one
I'm
input
coming
of
to you.
mine?
I'll just check with other
fine.
panelists. Dr. Nirupama, do we have Dr. Nirupama? Dr. Nagavani Prapurna just talked about. Do we have Dr. Anjani?
Yes, ma'am. Anjani is
Yes,
there, ma'am.
Yeah,
Yes,
so
ma'am.
we have some inputs from you, Dr. Anjani. No?
Ma'am, in the first scan, it's good evening, ma'am. In the first scan itself, as we have seen less liker, I want to evaluate the patient with certain investigations like baseline thyroid, sugars, hypertension, and explain the patient that this might not continue because of this reason. As a sac is less with amniotic fluid is also less.
Okay. Yes, Dr. Rekha, for your comments.
Yeah, just it is just to add to whatever the previous panelists have told. According to all of us, I feel it is the chromosomal and genetic abnormality is the first reason in these cases, and the thyroid or blood sugars or dehydration. So very, very rare in early pregnancy to cause problems. So it is a genetic and chromosomal. One should be extra careful.
You can have hyperemesis, Dr. Rekha. You can have hyperemesis.
No, I'm saying yes.
Can be one of the causes.
Yeah, I'm saying the first cause will be chromosomal. These causes come next. That is what I said.
Yes.
And that is why, as Dr. Anjani said, counseling the patient and her husband is very, very important medico-legally, because when they come next time, the heartbeat is not there, especially the heartbeat was there previously. That becomes a great difficult thing for us to convince them. Second thing, we have to look for the size of the yolk sac also in these cases.
Yes.
Because most of the time it will have a very big 7 mm, 8 mm yolk sac also, which may be an added finding there.
Yes. So that is how, right in the first trimester, right at the first ultrasound, you can have some idea regarding the pregnancy outcome or prognosis of this pregnancy, how it's going to, go through the journey. So rest, everybody, every obstetrician know how to manage this, but this was the important point which we wanted to discuss. So coming to Dr. Ganga Bhavani. Can we have Dr. Ganga Bhavani?
Yes, ma'am.
Yes. So good evening, Dr. Ganga. Here we have this primary gravida, 4 months amenorrhea, and she has no complaints. She just comes to you for routine checkup. You examine her vitals are normal, blood pressure is also normal, but you find that the uterine size is comparatively less as compared to the gestational age. So you send her for ultrasound.
What, madam?
16 weeks pregnancy, placenta is anterior, but like severely less. Liker is severely less. Internal os is closed. What can be the causes? How do we investigate and manage this patient?
As the size of the uterus
Yes, Dr.
is
Ganga.
less, size of the uterus is less, we can think of IUGR or oligohydramnios, madam. We have to think of oligohydramnios.
Okay.
The cause of oligohydramnios we should investigate either due to preterm premature rupture of membranes or either placental insufficiency.
What else? What is the source of amniotic fluid in addition to the production by the placenta, the urine by the fetus? Right?
Due to placental insufficiency resulting in the flow of blood being redistributed to the fetal brain rather than the abdominal kidney. This causes poor urinary output and causes oligohydramnios. Or either due to renal
So you can have, you mean to say you can have leakage of the amniotic fluid, that is PROM, or you may have the decreased production. Okay. So in decreased production, you said placental insufficiency, but at around 4 months, okay, what else can be the causes? How do you have to think and guide her for investigations?
You have to see for fetal kidneys any renal agencies. Genetic causes, chromosomal anomalies.
Yes. What kidney problems can have this oligohydramnios?
Viral infections may be the cause.
Kidney.
Renal agencies are non-functioning fetal kidneys.
Yes. Bilateral multicystic kidney. And also uropathy. Yes. What kind of viral infection? They usually cause polyhydramnios, if you remember, but sometimes yes. What investigations you want to do for this patient?
First, we should do perspectrum examination to check any rupture of membrane.
Yeah.
And we have to do transvaginal sonography to see the length of the cervix, the internal os, and pore water. Then uterine artery to check for placental insufficiency, uterine artery PI should be done. And we check for any anomalies. And blood investigations have to do oral glucose tolerance test and predictors of PAH also we should check.
Okay. So you have taken the history. There is no history of leaking. She is not feeling like weight all the time, or she has passed some fluid. When you examine, you find that the symphysiofundal height is little less. When you do the post speculum examination, maybe you don't find the pull of liker, but you still you still have a doubt that she can have leaking. How do you confirm that she's got leaking?
In speculum examination, we'll see the pool of liquor in the vagina.
She doesn't have, suppose once she has already, everything is leaked out and she doesn't have any liquor to leak.
Bedside test will be there, madam.
Yes.
Bedside test for insulin-like growth
what are
factor
they?
protein.
Yes.
Which is in the amniotic fluid.
Yes.
If it is positive, it confirms the leakage.
Yeah, the simple test like Ferning, you can go for Ferning. Okay, Ferning and Amni check. As you said, the insulin-like growth factor, that test Amni check you can go for. You can have the sanitary napkin which have the color change. Okay. So Rekha, do you want to add anything here on this?
Nothing much to add.
Mm-hmm.
Nothing much to add. Is just to summarize on this slide that
Ah.
one is differentiate between whether there is leak, occult leak, or no leak, and it's an intrauterine problem.
Yeah.
But keep high index of suspicion about leak and complete dry labor also. Just because there is no pool, nothing, don't think that it is only intrauterine problems.
That is what the message to be given, right? And then, of course, when you go ahead with ultrasound, so first and foremost, you have to rule out the congenital and structural anomalies, especially the renal angiogenesis, as we said, obstructive uropathy, or maybe even the bilateral multicystic, totally non-communicating kidney or non-functioning. Okay, so if at all it is with a small baby, small for gestational age baby and the severe oligo, then you have to definitely look for the signs of placental insufficiency, as you already talked about. But if it is, it is now 16 weeks only, definitely you have to go ahead with the karyotyping and amniocentesis and the further investigations to rule out the genetic, the chromosomal aberrations as well. So considering the rupture membrane as a cause of oligohydramnios, bedside test, I told you that you can go ahead with Ferning and this Amni check test. Okay. So once you rule out that, then how do you manage this? If you have ruptured membranes, you have to, terminate this pregnancy. If you don't have the rupture of membranes and you find that there is adequate liquor or little less liquor, then how do you manage this case?
We have.
Yes, Dr. Madam Pani, we can go ahead with you. Madam Fani Kumari.
Yes, ma'am. Yes, ma'am.
How do
if
you
it is associated with placental insufficiency, because of the risk of preterm delivery is more, we'll keep the patient in bed rest and regular clinical examination by monitoring the symphysiofundal height, and we'll give to prevent the early contractions, we'll give either progesterones, injectable progesterones weekly once, or otherwise oral progesterones and tocolytics. And if approaching around 30 weeks like that, we'll give steroid also.
Yeah, but tocolytics, no, because she is not having any uterine contractions, and prophylactic tocolysis is not allowed. Even when indicated, long-term tocolysis is not allowed as per the evidence goes. So even when you want to go for tocolysis, it's only what is called as a short-term tocolysis. That is only for maximum of 3 days until the time when your magnesium sulfate is given for neuroprotection, or your steroids are given, or maybe you are planning to transfer this in utero. Okay, so this is only the rationale for the tocolysis. Okay, so for this case, definitely the tocolysis is not indicated. So when oligohydramnios is associated with placental insufficiency and also the higher rate of preterm deliveries, these cases will carry poor prognosis. Amniotic fluid also allows the fetus to move freely, and that is why this fetus, if it is very severe oligo, then it will develop muscle contractures and even some
and pulmonary hypoplasia also.
Pulmonary hypoplasia as well. Okay, so if it is uterine PROM, then of course the uterine contractions will start within 24 to 48 hours on its own. If it doesn't, then you have to actually induce. Okay. Correct.
If it is associated with multiple anomalies, we'll advise the termination and counsel the patients for termination.
Perfect. Okay, so if no anomalies, now no leakage, no anomalies, no chromosomal problem, then of course you have to try your best to conserve this pregnancy for continuation. And in that case, you have to rule out the hyperglycemia and hypertensive disorder of pregnancy. And if at all it is present, you have to manage accordingly. So as you have already listened to the screening for fetal growth restriction, I'm sure you all are well versed with the Dopplers. So we will not talk about this Dopplers, but how do you carry this pregnancy ahead from such an early age? We can have Dr. Lakshmi, we can have Dr. Prapurna, Nirupama. Please, one point from you. How do you take this pregnancy ahead?
Ma'am, if it is a placental insufficiency, we can keep her on ecosprin to increase the blood supply.
Right.
And also we can keep her on this. We can give her a hydration therapy like IV fluids, or else we can keep her on this leucine granule sachets, which will increase the nitric oxide and they'll improve the supply.
Okay. So FGR, whether there is any evidence to this, we will listen to the management also. But yes, definitely, when you do ultrasound, you find that there is no leakage, there is adequate fluid inside the uterus, and the cervix is not open but short cervix, then definitely you want to go ahead with the vaginal micronized progesterone, right? That can keep the uterus quiescent, keep the, sometimes even there is a evidence saying that vaginal progesterone also improves on the cervical length in cases of short cervix, right? That is according to FIGO, and that is how you have to give the vaginal progesterone. And then of course the various NOS, as you are talking about low dose aspirin, definitely here in this case aspirin 150, and of course the high dose calcium and the various other supplementation and the periodic monitoring. How frequently do you want to monitor this pregnancy, and when do you want to deliver her? Yes, Dr. Nirupama, Dr. Anjani. Oh, where are our panelists? Dr. Ganga Bhavani. Yes.
We maintain the pregnancy at least up to the 34th week.
Okay. 34 weeks. Definitely we want to pull on the pregnancy till 34 weeks.
Yes.
Because by the time you have, given her magnesium sulfate, given her steroids, and because the pregnancy, if at all, suppose you feel that even at 34 weeks, you are carrying the pregnancy well, when you do the Dopplers, they are satisfactory, then you want to terminate or you want to continue this? What is the indication for termination or induction of labor?
If the Doppler studies are abnormal.
Yes. What is the abnormality that compels you for induction of labor?
High resistance flow in the umbilical arteries and middle cerebral artery flow alterations.
Okay. So that is absent or reversal of
brain sparing effect. Brain sparing effect.
Yeah, but then it is absent end-diastolic flow. That is on priority. And when you have the abnormalities in the middle cerebral artery flow as well. Okay, so let us go ahead with the next.
Other two indications for termination would be fetal death or maternal chorioamnionitis.
Yes, that is definitely there because we are thinking on a positive note that we have brought this pregnancy up to this point. So when do you want to? So if there is no abnormality, then when should we terminate? Okay, so do we have Dr. Shravani joined? No? Devisri, do we have Dr. Shravani?
Yes, ma'am. Yes, ma'am.
But we can't see her also, and she's not responding also.
Madam, I'm here only, ma'am.
Okay, please go on.
Yeah. So, Dr. Lakshmi Kiran.
I think Dr. Shravani wants to talk.
Yeah, please go ahead. She's Dr. Lakshmi Devishri. No, we don't see Dr. Shravani here. So,
ma'am,
she's there.
Shravani, ma'am, please respond. Ma'am, she's on the line.
Ma'am, I'm here.
Please stop, Dr.
Go ahead.
Shravani.
Please go ahead. We want you to answer this.
Okay, ma'am.
So we have this, G2P1A0, second gravida, 34 weeks pregnancy. She comes to you with pain in abdomen and of course difficulty in breathing, less fetal movement. Pulse rate is 100, BP 120/80, pallor present, mild, pedaledema plus. Uterus is over distended, tense, fetal part not well palpable, but fetal heart is good. There's no definite contractions observed in 10 minutes. Only she is complaining of pain. When you do examination, internal examination, os is patulous, 1 centimeter, tense bag of membranes, no show, presenting part high up. Ultrasound says AFI 22, apparently no anomalies. Okay, AFI I would say here more than 25, not 22. Diagnosis, what is your diagnosis and what are the problems associated? Whether anything can be done prenatally for this patient?
Most probably it is acute polyhydramnios, ma'am.
Okay. How do you know it is acute or chronic?
Sudden of symptoms like shortness of breath and pain abdomen.
Yes. It is a symptomatic patient. Definitely, she's got polyhydramnios. Now, you let us know that what are the problems associated with polyhydramnios and what can be done for her. How do you manage her? She's 34 weeks.
Problems associated with means acute polyhydramnios and premature rupture of membranes and preterm onset of labor can occur, ma'am. And sometimes if she go into early labor and if there is rupture of membranes because of unengaged head, cord prolapse may occur, leading to fetal distress.
No. Yeah, it can be called. Okay, but then before that, they can be, yeah, there can be fetal malpresentations as well.
Yes,
Right.
ma'am.
Okay, and when she goes in labor, suppose a sudden rupture of a bag, definitely she may land up into cord prolapse or abruptio placentae, that is called as sudden decompression, right? So because of this, she can land up into abruptio placentae as well. So after delivery, whether she's at high risk for something?
Postpartum hemorrhage.
Yeah, atonic PPH, uterine hypotension. So she's also, at a high risk of fetal death. The reason may be unknown. Because, usually the polyhydramnios is associated with either fetal anomalies or the hyperglycemia, right? And there are so many other reasons. So what are other reasons you will think of before going for management? What are the other investigations you will go for apart from
Maternal evaluation of sugar, like glucose tolerance test will do, ma'am.
Okay.
And we ask for any history of previous pregnancy with polyhydramnios. And fetal TIFA will review, we'll see again. And if there is any esophageal...
What are you expecting in fetal target scan?
Tracheoesophageal fistula, which will swallowing the amniotic that may lead to like
esophageal or duodenal atresia also.
Yes, ma'am.
Yeah. And open neural tube defects, the CSF is draining directly into the amniotic fluid, right? So, of course, the various infections as well as the genetic abnormalities. What else? Some types of hydrops because of the immunization, certain viral infections like torch or pyrovirus infections, and syphilis, all of you know. Usually it's a large baby, swollen edematous. You have
large placenta and large baby.
Placenta is also larger one, dusky hue. So all these investigations you have to do to come to the diagnosis, right? So these are the risks associated with polyhydramnios you are already discussed about. Now, how do you manage this patient of polyhydramnios? Yes, Dr. Sapna.
How to, if already it is around 34 weeks, first we have to give procolytics for about 48 to 72 hours. And then give steroid 2 doses 12 hours apart.
Okay.
Betamethasone 12 milligrams with 24 hours apart, or dexamethasone 6 hourly. 4 doses.
Okay.
And then and magnesium sulfate injections to as for neuroprotection.
Okay. Magnesium sulfate, they say that it should be given only up to 32 weeks. But beyond 34 weeks, there's no need, there's no evidence to support it. That is what it is said in the literature. But yes, to be on the safer side, we give magnesium sulfate up to 34 weeks. You're right. Okay. So if it is 8 to 11, it is mild polyhydramnios, 12 to 15, it is moderate, and more than 16, it is severe. So our patient has got severe polyhydramnios, right?
Yes.
Yeah.
If
So
she entered into the labor, go for the controlled ARM to avoid cord prolapse
should we
during
do?
labor.
Okay. Should we
Can
do?
we-
Yes, Dr. Ramya. Do we have Dr. Ramya?
Yes, ma'am.
Yeah, please go
Good
ahead.
evening, ma'am.
I want all of you to please speak on your own. I'll be very happy. Please go ahead. How do you manage this case?
And during labor and delivery,
Dr. Ramya, yes.
Yes, ma'am. If she gone into labor,
Mm-hmm.
we monitor labor with CTG,
Mm-hmm.
and then we do controlled ARM with head fixation.
Yes.
Immediately after rupture of membranes, we check for cord pulsations
Mm-hmm.
and CTG.
We do not
If there
leave
is
our
any-
hand, which is fixing the head.
we should not leave the hand.
Okay.
If we feel the pulsations,
Yeah.
we should not remove the hand, and we should immediately shift the patient to OT
For what?
for immediate delivery as cord prolapse.
No, you are saying
Right.
that you should do controlled decompensation. That is the controlled ARM, right?
Yes, ma'am. Yes, ma'am.
Okay. So once you fix the head, you do controlled ARM. That means you are slowly pricking and
Slowly
removing
releasing.
the
Yes, ma'am.
fluid. But then after that, should you induce her with oxytocin or what?
Oxytocin.
Yes, ma'am. If head got fixed, I mean,
Yeah.
if there is no cord pulsations felt, definitely we can.
There's no cord pulsation felt. There is no cord felt because we don't
yeah.
want the cord to be prolapsed. No, we don't expect every time. But yes, you
You
just
make-
try to feel that there is no cord prolapse. Then you go ahead with the induction.
Oxytocin.
Right. That is
to
oxytocin.
make sure that there is no cord. That is
Yeah.
important for not the cord pulsation.
Yeah, that is what I'm saying. There is
Yeah.
no cord prolapse. That is
Yeah.
what you have to make sure before going for oxytocin
Yes.
infusion to start. Okay. Then what to do?
We should look for after the delivery of the baby.
Ramya, put your video, no? Dr.
Sorry, ma'am.
Ramya. Yeah.
We should check for any postpartum hemorrhage, ma'am. Atonic PPH, there are more chances.
Yeah, but we have just induced her, no? How do you conduct the delivery and monitor the delivery labor?
We can continuously monitor with CTG, ma'am. And autograph we can maintain.
Okay. How frequently you want to say continuous electronic fetal monitoring, right? Suppose you don't have, then?
Sorry, ma'am.
Suppose we don't have continuous electronic CTG or fetal monitor, then how should we monitor this patient in early
Heart rate should be checked, ma'am.
Yeah. How frequently?
At least half an hour.
Oh, no.
Every 15 minutes.
Our patient is a high risk. Even for first stage of labor, it should be every 15 minutes.
Every 15 minutes.
Okay, every 15 minutes. And at least if at all you are, taking the maybe intermittent recording also, intermittent fetal monitoring by electronic fetal monitoring also. If not continuous, maybe intermittent. But with stethoscope or Doppler, definitely every 15 minutes during first stage and every 5 minutes or maybe even every after every contractions during second stage of labor, right?
And watch for 1 full minute at least when you watch.
Yes. That is
Because
what.
decelerations can happen.
Okay. So, Dr. Anjani, suppose this patient you had diagnosed earlier that she's got polyhydramnios. How you would have managed this patient?
Ma'am, if I would have diagnosed before 34
We already
weeks.
discussed, but just to revise. Yes.
Ma'am, if it is before 34 weeks, can we have sildenafil citrate tablet?
For what? She's got polyhydramnios. She doesn't have oligohydramnios. Okay.
Hello.
Yes, Dr. Anjani.
before 34 weeks. Can we go for amnio reduction, ma'am?
That is what I'm asking, whether what are your plans?
Ma'am, if it is before 34 weeks, I would like to go for amniotic reduction, ma'am.
Okay. And what else? Suppose she has hyperglycemia.
Control of sugars, if she is a diabetic, her sugars have to be controlled, ma'am.
Okay. Suppose this fetus has got some sort of cardiac failure, maybe dysrhythmias.
RH incompatibility, or if it is the causes, it depends upon the cause, ma'am. If it is RH incompatibility, then I would like to see
the fetal medicine specialist should come into action. Okay.
Yes.
The fetal medicine specialist should come into action, because if she is a case of RH isoimmunization and if she is developing high drops, then of course the details of investigations, her titers, what is the titer, whether it is critical,
transfusion.
transfusion, or whether sometimes she may even if it is because of twin to twin transfusion,
transfusion.
then you have to go for laser occlusion of the placental anastomosis. If it is for some placental tumors, then we have to go for the occlusion of those
the feeding vessels.
Yeah. So all this, you have to know what is the cause, and accordingly you have to monitor or manage. As we said, there can be some problems with the fetal swallowing, right? There can be some problems with fetal swallowing as well. So that also you have to see what else can be done. And serial amnio drainages, as you have said, in modern obstetrics, actually we are not doing this, right? If at all you are doing, please share your experience. If at all somebody is doing, but yeah, is somebody doing this?
No, ma'am. Actually, I have seen one case with all polyhydramnios of AFI25, and I checked for the glucose tolerance test, which was normal. Then I repeated and I advised her to take less sugar and everything, and I repeated the scan in 3 days or 4 days. And if there is more increase, I have kept her on indomethacin.
Right.
Sorry, ma'am, indomethacin.
Yeah, so that is what, previously, I'm sure 3 decades ago, we used to go for amnio drainages or amnio reduction. But nowadays, I don't think we are going ahead. If at all, we leave it to the fetal medicine specialist. And yes, as an alternative and effective method of treatment for maternal administration of indomethacin. But all of you know that what indomethacin does is, it leads to fetal ductal constriction and premature closure of the ductus arteriosus, right? So we have to be very vigilant in monitoring the fetal heart as well. Fetal echocardiographic study is necessary for such patients, right? So we come to the 4th case now, Dr. Lakshmi Kiran. Dr. Lakshmi Kiran, do we have Dr. Lakshmi Kiran on board? I could see her.
Ma'am, I'll try calling ma'am.
Yeah, please. Because she is supposed to answer this or discuss this case. We have this third gravida, para 2 with previous 2 FTNDs, and she comes to you with 9 months amenorrhea with leaking per vaginum. So maybe around 2 days ago, and now she comes to you with labor pains from yesterday. Pulse rate is high, febrile, but dry tongue. She's dehydrated. BP is normal. There's no pallor or pedal edema. Uterus is full-term contractions, very good, 35 to 40 seconds every 3 minutes. Head is fixed, fetal heart is 120 per minute, and she's 6 centimeter dilated, 75% effaced. Membranes are upset, but liquor is thickly meconium stained, station at -2. Pelvis is adequate. Normotensive, non-anemic, no oligohydramnios diagnosed previously. Why it is meconium stained, and how will you manage this patient? That is the question for Dr. Lakshmi Kiran. If she's
Ma'am,
not
can we pass on the question to any another panelist?
Yes, that is what I'm saying. I think Prapurna, Dr. Prapurna.
Yes, ma'am.
Yeah. Lakshmi Prasuna, I could see actually.
Dr. Nirupama is there.
Yes. but then
Ma'am, Dr. Lakshmi Prasuna is not a panelist, ma'am. Prapurna Prasad is a panelist.
Prapurna is a panelist.
Yeah,
Yes.
yeah. Prapurna panelist.
And Dr. Ramya. Dr. Ramya, you can take up this case.
Yes, ma'am. She is a case of 9 months pregnant with
Yeah.
2 previous normal deliveries,
Yes.
with history of PROM since
Yes.
2 days.
Yeah.
And she is in labor.
Yeah.
So she's
And now she's
on,
got thick meconium stain liquor.
yes, on perspiculum examination, we can see thick meconium stain liquor.
Mm-hmm.
And the station is -2 with 6 centimeters dilated, 75% effaced.
Yeah.
With good pelvis.
Mm-hmm.
So the reason for oligohydramnios,
What do you think? She will deliver vaginally? You want to wait or take her for cesarean section?
as she had previous 2 normal deliveries,
Mm-hmm.
we can closely monitor her.
Yeah.
With
And
the help
now
of
she's got
CTG.
very good contractions. She's already 6
Yes.
centimeters.
Yes,
Yeah.
we can try for normal vaginal delivery
Okay.
with close monitoring of CTG.
Okay. What are you afraid of? Suppose the baby lands up into problem. Baby is either severely distressed or later on if the baby goes into
Because of hypoxia and this meconium stain liquor, we might expect like fetal hypoxia and then chemical pneumonitis because of this meconium.
Okay.
So to reduce this, what we can do is like amnio.
Okay. So Dr. Nirupama, we want your opinion on this. Dr. Nirupama.
Dilution.
Dr. Nirupama. I could see Dr. Nirupama here, but then
Yeah, even I could see.
Yeah, I'll call ma'am, just a minute.
Yeah, because she was here. By the time Dr. Ramya, you can continue.
Yes, ma'am. So otherwise, she is a plain case.
Mm-hmm.
And there is no history of oligohydramnios in the previous ultrasound.
Okay.
This
So
meconium
she's
stain
already she has leaking. That's the reason the liquor is less.
Yes.
Yeah. Okay.
And the reason for this meconium stain liquor, which might be due to any placental insufficiency because of hypertension, preeclampsia, or any other causes. And then
Is it so? Is it so?
maybe
Everything is
just
given
sign of a
normal.
mature baby like gut maturity.
See, what I'm trying to say is this was absolutely a normal pregnancy, 3rd pregnancy, full term. Then it is because she has leaking. Okay. She has leaking.
Cord
and
compression.
Cord compression. Perfect.
Cord compression,
Shravani.
yes.
Dr. Shravani, go ahead.
Because of continuous leakage, even the parameters are normal previously. Because of the continuous leakage since 1 to 2 days, the liquor has been decreased, and that leads to compression, and that may lead to.
Because that she has very strong contractions here. Yes. Yes. So that is the reason that she is landed up into cord compression and fetal distress, fetal hypoxia, acidemia. That's the reason she is landed up into thick. And because the liquor amount is less, now the liquor has become thickly meconium stained. Because even if otherwise, if it has passed the meconium, if the volume was more, it wouldn't have been thick meconium stained, right? But now that it is a thick meconium stain, even though you are sure that it is 3rd gravida, previous 2 normal deliveries, you are not supposed to directly go and try and stretch her to vaginal delivery. You have to discuss with the patient and relatives, explain the pros and cons, that even though previous 2 deliveries are normal, you're supposed to explain them that this baby may land up into complications if at all we wait further. So what is your choice? So which is called as informed decision making. Okay. So even after they agree to it, then you can go ahead with whatever corrective measures of IV fluids, left lateral position, oxygenation, and then of course the augmentation of labor. You can go ahead and deliver her vaginally, maybe with the instrumentation as well. Okay. But what I want to stress here in this case, that you have to discuss with the patient and relatives that in what condition they have come to you, what is the prognosis right now, and what if they wait for vaginal delivery, what if they go for the cesarean section right away. Okay. So all these things have to be, yes. Anybody want to add anything?
Have a pediatrician while delivering, so that
Yes,
you hand over the baby
neonatologist has to be
immediately.
there.
Yes, and explain to the patient about the meconium aspiration, NICU admissions, etc.
Ma'am, in this case, after discussing with the patient and attendants, can we go for amnio infusion through vaginal route?
Yeah, that is your choice. If at all you are comfortable, you are well versed with the procedure, then of course you can go. But then you don't have to deceive them that this is going to improve the prognosis definitely, because evidence doesn't support this. Okay, what your aim is to deliver the baby at the earliest, hand over to the neonatologist and see that the baby doesn't develop complications, right? So even if you feel that
heart is also important.
Even if you feel that she can deliver vaginally safely, you have to explain it to the patient and relatives that you have come to us in this condition. Maybe sometimes even if we go for cesarean section directly, we may not save the baby from complications. We can save the baby, but some sort of morbidities may remain and the baby has to go through it. Okay. So everything has to be explained because the patient has come to you in this condition. That is what. Okay. What kind of now fetal monitoring we have talked about it? This is a case where even when you are doing amnio infusion, you're giving oxygenation, trying to augment the patient and deliver fast. In spite of all this, you have to have a very, meticulous electronic fetal monitoring or meticulous fetal monitoring, right? So that is what is the message for this. So we have, I think this will be the last case. Let me check whether sir has joined. Can somebody
No,
keep
I just checked. He hasn't. I just checked. Sir has not joined.
Okay. So
Dr.
we'll
Shah.
go ahead with the last case. And Devishri, can I request you to please call sir? I think he should be ready now. The registered primary gravid of full-term pregnancy, normotensive, non-anemic, came in latent phase of labor. She started having strong uterine contraction after 12 hours of admission. ARM was done to augment the labor, and when she was 3 centimeters, 75% effect, Liker was clear. Within few minutes, she started having very strong contractions. Suddenly, she became restless, breathless, and thirsty. So, pulse rate, pulse and BP not recordable. What are the differential diagnosis? How do you manage? Dr. Prapurna. Dr. Prapurna.
Yes, ma'am.
Yes.
Ma'am,
Ma'am,
this is the case of primary gravida full term with no previous history of any complications. I mean,
what is the
either hypertensive and all. It might be the patient just went to hypovolemia or any thromboembolism happened, or in some cases we can find amniotic fluid embolism which can happen.
Sudden maternal collapse.
Collapse, yes, ma'am.
What are the differentials you have in your mind? After the rupture of membrane.
Amniotic fluid
embolism.
Amniotic fluid embolism, because the ARM done.
But what can be the differential still? ARM done definitely, amniotic fluid embolism, pulmonary embolism, and what else?
Hypovolemia, hypoxia.
Any
hypothermia.
You can have any sorts of blood transfusion reaction or anaphylactic reaction also to some drugs, right?
Drug-induced reactions.
Yes.
And intracranial hemorrhages due to severe hypertension, which is pre-existing.
So how does this pulmonary embolism or amniotic fluid manifest? What are the different phases and how do you manage it?
In the initial phase, there will be pulmonary vasospasm, leading to hypertension, and then right heart failure. And then the second phase, there will be progressively to left heart failure.
Dr. Sneha, 1 minute.
Developing pulmonary edema.
Yes.
Dr. Ramya madam, 1 second. I spoke to Shah sir, PK Shah sir. He said he's trying for the past 15 minutes, he's not able to join. What I told him is that to send his PPT to one of the people like Sahiti here, and sir can join from mobile and speak.
Why he's not able to join?
He said he is not able to join.
Wait. Sahiti, do we have, please call Sahiti. I will ask her to help Dr. PK Shah sir.
Yeah, that's what I told, whether Sahiti can help him. That's what I asked him. That's what I want to ask you. In worst case, he can send his PPT and all that. And he can speak from mobile, etc., etc. meanwhile, if we do this, then we can continue the panel till Sir joins.
Yeah, so Sahiti is calling him by the time we finish
Yeah.
up this case. Yeah.
Yeah,
Say-
exactly. Exactly.
Go ahead, Dr. Ramya.
Yes, ma'am.
Who is
Then
speaking?
leading
Yeah.
to respiratory distress syndrome, finally landing in coagulation abnormalities.
Yeah. So you need a multidisciplinary approach, right? Basically,
Yes, ma'am.
basically amniotic fluid embolism is a diagnosis of exclusion, right? You
Yes.
have to rule out, by the time you do all the, you have to do very aggressive management as far as, for any maternal collapse, what to do, A, B, C, D, that is what you have to follow. Maintenance of airway, see that she's breathing, not to intubate her, take her on ventilatory support, see that her circulation is well maintained, otherwise aggressive fluid resuscitation, blood and blood product, and correction of hypovolemia. Even the drugs like inodrops, vasopressors, we have to start, and depending upon whether she's into acidosis, we have to give her sodium bicarbonate. That is how we have to go ahead. So just to conclude, we have discussed these interesting cases which we face in day-to-day practice. But just to conclude, why we give so much importance to amniotic fluid. Amniotic fluid is a clear watery fluid. Initially during early pregnancy, it has only water and electrolytes, but later on it becomes cloudy, where you have fetal hair, vernix caseosa, and the material released from fetal lungs. Also, I told you that fetus swallows the amniotic fluid. It passes from GIT and kidneys and then back as urine. Fetus inhales and exhales amniotic fluid and thereby stimulates lung development. The quantity also is naturally adjusted. We know that 8 to 25, that is the normal AFI. Less than 8 we call it as oligo, and more than 25 we call it as polyhydramnios. Both has its own problem, and that decides the prognosis of the pregnancy. The baby has taste, the liquor has taste, smell, and sound as well. We heard the white noise. At delivery also the fluid escapes first to clean the passage. That is what it said, to welcome the baby or to protect the baby. So quantity as well as quality of the amniotic fluid both matter as far as the growth, development, and survival is concerned. And that is why we have to give much importance to amniotic fluid and keep a close watch. So friends, I just take this opportunity once again to thank all of you for having me here on board and having the collaboration. And thank you so much, all of you, for the active participation in the panel discussion. Friends, I would just tell you that I'm a person who works silently, not into any politics. And I wish to go ahead with my merits only with all of your support. So I believe in work for a cause, not for the applause. Live life to express and not to impress. Don't strive to make your presence noticed. Just make your absence felt. So with this, I would like to thank all of you once again. And we just hope that Dr. P.K. Shah sir join and we get nice lecture on the FGR management. Over to you, Dr. Devishri, and I think anybody can make comments if at all you have anything.
Thank you very much, ma'am, for a wonderful panel discussion. And all the best, Madam Sneha Bhuyar. All the best for the present coming elections.
Thank you so much.
Madam.
Thank you.
I am requesting on my behalf also, requesting all of you to presidents and societies of all the 4 societies with folded hands to vote for my candidature, that is medical disorders in pregnancy. I am Dr. Rekha Rajendra Kumar, President of Bangalore Society. Thank you, Dr. Sneha, for a very vibrant panel and panelists for a very vibrant interaction. Thank you so much.
Thank you, ma'am.
Sahiti has informed. Shall I call, sir?
No. What did you say?
I request all the panelists to please unmute yourself. All the panelists.
Has sir joined?
No, ma'am. Sir is
Sahiti? No,
restarting the laptop.
she has displayed CV, no? Sir will join soon, that means. Hi, Sahiti.
Yes, ma'am. Sir is restarting the laptop and checking once.
Yeah, but then what was the problem?
Sir was able to join, ma'am, but video is not working, it seems. So sir is checking the video part.
Okay. But is he here online? Not yet.
Sir has not joined yet. There's some problem for him to join.
Yeah, let us wait because he's trying. No? Do we have Dr. Aruna Kumari? Hello, Dr. Aruna Kumari.
Madam.
Yeah.
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 We are waiting, Dr. Pikesa has had to join us, madam.
Yeah. That is what, in fact, I have told Sahiti to help him. So,
Yes, ma'am.
yeah, let us wait for that. By the time, if you have any comments, any discussion on even the fetal growth restriction or this amniotic fluid, all of you are welcome to make few comments.
Madam, nowadays, the amniotic oligohydramnios has become very common without any underlying cause. The baby is very healthy, up to mark, no fetal growth restriction, but this is oligohydramnios. Around less moderate, around AFI will be around 6. Is it significant, madam? Should we go ahead with delivery of those babies?
No. I think because see how what did we discuss, that it's amniotic fluid alone is not a parameter of fetal well-being. Even when we are doing this as a biophysical profile, it is one of the parameters, right? So yeah, we are going by the fetal circulation. So we are following the fetal Doppler, and that's the reason we discussed that. What are the indication for induction of labor? We are not going only by the parameters of amniotic fluid. So whenever you have normally you have seen all the Doppler, Dr. Lakshmi Rinke has very nicely shown you all the graphs as well, that initially you should have a good systolic wave, but you should have a very good diastolic wave as well. And as the pregnancy progresses, normally you should have a good diastolic flow. Whenever you have decreasing in diastolic flow, that is a alert that gives you that yes, there is definitely some problem. But if at all you have absent end diastolic flow, and then the next stage, which is a ominous sign, that is the reversal of end diastolic flow, that is an indication for termination of pregnancy, that is induction of labor. The fetus is what is called as salvageable. Yes, I can see, sir. Sir, very good evening and hearty welcome to you, sir. We have already introduced you and we are eagerly waiting to listen to you, sir.
Yeah, I'm sorry.
No, sir, no, sorry.
No, not at all, sir.
Yeah, please.
Sir, thank you so much for joining.
Please go
You are
ahead
able
with
to
your
display
presentation.
PPT, sir?
Saiti, has sir shared his PPT with you?
Yeah, share.
They are doing that. They are doing that.
Okay.
Meanwhile, can I
Yes.
introduce chairpersons, ma'am? Just to save the
Yeah,
time.
Please go ahead.
Sahiti, can you please share the slides, CV slides of our chairpersons?
Yes.
Thank you.
Where it is.
I would like to introduce our chairperson, Dr. K. Satyanarayana, sir. Completed his MBBS from Rangaraya Medical College, Kakinada, MD from PGI, Chandigarh. Worked as an assistant professor in Department of OBGYN in Rangaraya Medical College for 8 years. Later resigned his government service in 2006. Because of his academic interest, still taking lecture classes for gynae postgraduates at RMC Kakinada. Currently, he is a managing director of a well-reputed OB-GYN center by name Sri Sai Raghavendra Super Speciality Hospitals at Gandhinagar, Kakinada Smart City. He is also the founder of Sri Sai Raghavendra Charitable Trust, which is rendering medical camps, public motivational programs towards national interest and self-reliance. He presented many scientific papers in various conferences, participated as faculty in many conferences. He got the Best Scientific Paper Award on gestational trophoblastic tumors. And we welcome you, sir.
Thank you very much.
I think this is my pleasure to introduce our president, Dr. Arunakumari ma'am. Graduated from Rangaraya Medical College, Kakinada, and in 1991, and university first in final MBBS. Ma'am completed her post-graduation from PGI Chandigarh in 1994. She is an ex-associate professor at JSL Medical College, Rajamundry. She is a senior OBGYN consultant at Harsha Hospitals, Rajamundry, and her areas of interest are infertility and high-risk pregnancy. Ma'am has started practice in, Ma'am was the first person, one among the first person to start Rajamundry Obstetrics and Gynecological Society at our place, and she conducted many CMEs and Andhra Pradesh State Conference in 2012 and 2021. Welcome, ma'am.
Thank you, Devashri.
I would request one of our chairpersons to please introduce Dr. P.K. Shah, sir.
Sahiti, please, sir's PPT slide.
Only in one line.
That we have already done, but it's our privilege to introduce you, sir.
Neha, can you hear me?
Yes, yes, sir.
Okay.
Only your, I think the angle of your laptop. Yeah, now we can see you better.
Sahiti, can you?
So just one word about Dr. P.K. Shah, sir. He is the most senior teacher and the best academician we have. And sir has served many positions in our Foxy, like he's our past president, Foxy president, and he's a past dean of Indian College of Medical Ultrasound. He's a past chairman of Imaging Science Committees, and he's a joint secretary, and many more positions.
Enough.
And he received many awards which we cannot count. Sir, now we are eagerly waiting for your talk on management of FGR.
Over to you, sir.
Share the screen.
Yes. Slideshow. Down on the right side.
Can you see it now?
It's not see.
Okay, shall I start?
Yes, sir.
Okay. Now, let me thank AMOGS office bearers, especially Dr. Kiran Purtukoti, Dr. Bipin Pandit, Dr. Rajendra Singh Pardesi, Dr. Madhuri and Abol, Dr. Sneha Bhuyar, who is the chairperson of Emergency Obstetric Committee of AMOGS. Thank you very much for having me as a part of this webinar. Unfortunately, I was not getting the internet connection in the hotel in Pune, where I have come for IAGE and AHGL conference. Luckily, things have been managed, and I'll start my talk. The first thing I would like to tell you is what is the difference between early onset IUGR and late onset IUGR. I was not there for the first talk, so I'm sorry if there is some repetition, but I'll finish my talk in 20 minutes. Early FGR before 32 weeks and late FGR after 32 weeks. Incidence is 1 to 2% for EFGR and 3 to 4 for LFGR. What is important is the placental damage is more than 30 to 50% in early onset, and there is a failure of invasion of spiral arteries in early pregnancy, whereas in late FGR, placental damage is less than 30%. There is a failure of invasion of spiral arteries in late pregnancy. In etiology, you can have PIH in early onset. There is no PIH in late.
Sir, I think your slides are not moving, sir. Please.
Your slides are not moving, sir.
I am not moving it.
Okay, sorry, fine. But it is not full screen also.
It is
Sir,
not full
please
screen.
share your full screen, sir.
I did it. You can't see it full screen?
No, sir. Slideshow. Just click on the slideshow.
I have to go back. I'll go to
Slideshow button, sir.
At the bottom.
No, I'll go to again
Okay.
slide share.
Okay.
Can you see now?
Yes, sir.
Yes, perfect.
Can you see it? Okay.
It's okay, sir.
So coming to biometry, indices, etc., they are almost same for both early onset as well as late onset. Now this is not moving.
Click on the slide, sir. Click on the slide and then it will move. Double click.
Okay. You can have oligohydramnios in early onset. The fluid may be normal in late. Coming to various Doppler indices, umbilical artery Doppler will show you increased resistance, or if it is severe, it can be absent end-diastolic flow or reversal of end-diastolic flow in early onset. Whereas, very important that in late onset, the umbilical artery Doppler may be normal. MCA will show you initially mild resistance, in mild cases, decreased resistance, and later on it becomes increased resistance. Whereas in late onset, there is always decreased resistance in MCA Doppler. Ductus venosus will show you earlier on increased resistance, and then comes absent of A wave, that is the third wave, and later on, the last part comes a reversal of third wave or A wave. Venous Doppler is abnormal in early onset, where it is normal in late onset. CPR is less than 1, but if it is less than 1 for late onset, it is important for decision making. Diagnosis is easy for early onset, whereas it is difficult for late onset. Whereas management is difficult for early onset and it's easy for late onset. Prevalence is lower for EFGR and higher for LFGR. Perinatal mortality morbidity is high for EFGR, whereas it is lower for LFGR. And long-term outcome is better for EFGR, whereas it is poor for LFGR. Now, coming to management of FGR, there is no effective intrauterine treatment. Objective of a correct management are early diagnosis, prevention and reduction of risk factors wherever possible, and surveillance of the fetus with fetal growth restriction. Delivery at the best moment. If delivery before 32 weeks of gestation, give magnesium sulfate for fetal neuroprotection. And if the delivery is before 34th week of pregnancy, give corticosteroids. Doppler ultrasound is the chief tool to decide management of FGR. What is the aim of delivery? Whether you just want a live fetus or intact survivability. The risk of intrauterine compromise has to be weighed against the potential risk from iatrogenic premature delivery. So when to deliver? Gestational age at decompensation is the primary determinant of perinatal survival. Neonatal care available dictates the gestational age of delivery for that center. If it is less than 32 weeks, every day gained is useful. Every week gained, the outcome is improved. Here, the venous Doppler helps delay delivery. If it is more than 32, 34 weeks, give steroids and deliver once. Umbilical artery shows you either absent end-diastolic flow or reversal of end-diastolic flow. Now, if you have a constitutionally small baby, how are you going to manage? She's not at a risk of hypoxia. It's genetically programmed to be symmetrically small, onset late second or third trimester, growth velocity maintained along 10th percentile. This is a normal Doppler study. Maternal and paternal size influence the birth weight. How do you manage antenatally? If the Liker is normal, monitor by 2 to 4 weeks, growth, amniotic fluid index, and Doppler. Deliver at term after 38th week and allow vaginal delivery. This was for I hope you have understood this.
Constitutionally small babies.
Constitutionally small.
Small babies.
Yes. Now coming to early onset fetal growth restriction, where it is because of placental insufficiency. Fetus is less than 10 percentile. There is a poor growth velocity, especially flattening of the growth curve in second and third trimester, and asymmetrically small baby is there. And the onset always occurs before 32nd week of gestation. What you will find? Abnormal umbilical artery, uterine artery Doppler, an abnormal middle cerebral artery Doppler, like either normal or low. And in first trimester screen, if you're done, you'll find low PAP if you have the reports. It's frequently associated with preeclampsia. Now, coming to antepartum surveillance protocol, early onset fetal growth restriction stage 1, mild placental insufficiency with high resistance in umbilical artery, cerebroplacental ratio less than 5th percentile, middle cerebral artery showing you less than 5th percentile, and the uterine artery showing you more than 95th percentile. Monitor with NST, BPP or VAST weekly. Do umbilical artery MCA Doppler weekly. Growth parameters and AFI weekly. And deliver at 37th week of gestation if all is normal by induction of labor, and you can allow vaginal delivery. Coming to early onset FGR stage 2, where there is a severe placental insufficiency. How do you know that? There is either absent end-diastolic flow in umbilical artery or reversal of flow in aortic isthmus. Now, if the gestational age is more than 34th week, give steroids and deliver by C-section. If the gestational age is less than 34 weeks, admit the patient, give steroids, do Doppler umbilical artery MCA, ductus venosus twice a week, and do C-section if ductus venosus shows a reversal of third wave, that is A wave. Coming to stage 3 in early onset fetal growth restriction, where there is low suspicion of fetal acidosis. How do you find out? Umbilical artery will show you reversal of end-diastolic flow, or ductus venosus PI will be more than 95th percentile. If the gestational age is more than 30 weeks, give steroids plus magnesium sulfate for neuroprotection. Deliver by C-section within a day if estimated fetal weight is salvageable. If the gestational age is less than 30, decision according to estimated fetal weight, NICU facilities. Give rescue steroids, magnesium sulfate if ductus venosus flow is normal. Do daily Doppler and do C-section if the ductus venosus shows reversal of A wave. Induction of labor with consent for intrapartum death should be taken. Coming to the last stage, that is early onset FGR stage 4, there is a pathophysiological correlate, there is a high suspicion of fetal acidosis. How do you find out that? Any one of these criteria, like ductus venosus showing you reversal of A flow, that is the third wave, fetal heart sound decelerations, do monitoring 12 hourly, depending on the gestational age, you can deliver by 26 weeks and always do C-section. Now this is in short, you can take a picture if you have a mobile and it is showing up well on your screen. The stage-based approach to management of fetal growth restriction, the early onset. I have given this thing in one slide. Take a picture, take a printout. If you want, you can laminate it, keep it in labor ward. This will save a lot of fetal growth restriction babies. Now, coming to antepartum surveillance protocol for late onset fetal growth restriction beyond 32 weeks of gestation, where you have mild placental insufficiency. Fetus is less than 10 percentile. There is flattening of the growth curve in third trimester, more than 32 weeks. Umbilical artery Doppler will be normal, but there is low PI in middle cerebral artery, and the cerebral placental ratio CPR is always less than 1. If you do uterine artery Doppler, it is abnormal. The Likert is either normal or low. It is not associated with preeclampsia. Monitor weekly Doppler, growth, and Likert. Now, in the same late onset FGR, if the gestational age is more than 37th week of gestation, deliver. You can do vaginal delivery. If the gestational age is less than 37th week, give steroids. Do uterine artery Doppler if the PI is more than 95th percentile, or if the CPR is less than 1. and the estimated fetal weight is less than third percentile. If any one of these three is abnormal, consider delivery. Monitor for serial worsening of middle cerebral artery, PI more than 90 percentile. What is the optimal gestational age to deliver the fetus of late onset fetal growth restriction more than 34 weeks? Delivery at 37th week of cases with increased PI of umbilical artery. Delivery at 37 to 38 weeks of cases with normal umbilical artery Doppler, but with modified middle cerebral artery Doppler. Timing of delivery is based on middle cerebral artery Doppler. Please remember this very clearly for late onset fetal growth restriction. MCA Doppler, very, very, very important. In cases with normal umbilical artery Doppler or with abnormal umbilical artery PI, but end diastolic velocities are present and good obstetrical condition, induction of labor can be offered, but rates of emergency section are increased. Early admission is recommended in women in spontaneous labor with a small for gestational age fetus in order to instigate continuous fetal heart rate monitoring as per RCOG. Fetal heart rate monitoring will be interpreted more cautiously than usual. Late onset IUGR onset after 32 weeks, PIH need not be there. There is a high index of suspicion. Umbilical artery Doppler may be normal. Always combine umbilical artery with middle cerebral artery, otherwise you will miss late onset IUGR. CPR is the one that will decide for delivery. CPR less than 1, try and think of delivery. Now, people say that a routine third trimester Doppler is very important not to miss out late onset IUGR. Many times you will find fetus dies in the last stage, in the third trimester, without any suspicion. These are all probably undetected late onset fetal growth restriction. As regards mode of delivery, fetuses with significant FGR should preferably be delivered in well-equipped centers which can provide intrapartum continuous fetal heart rate monitoring, fetal blood sampling, and expert neonatal care. What about vaginal delivery? It can be allowed as long as there is no obstetric indication for C-section and the fetal heart rate is normal. Fetuses with major anomaly incompatible with life should also be delivered vaginally. So when will you do cesarean section? In all cases of fetal growth restriction with features of acidosis, C-section should be done without trial of labor, and that includes repetitive late decelerations, poor biophysical profile, reversal of end-diastolic flow in umbilical artery, abnormal venous Doppler, and blood gas analysis shows acidic pH on chordocentesis. But very important thing which I want to tell you is the treatment that does not work. Remember this, the treatment that does not work, and that includes bed rest, maternal oxygen supplementation, maternal nutritional supplementation, low dose aspirin, beta blockers, calcium channel blockers, plasma volume expanders, nitric oxide donors, the GTN patches, L-arginine, vitamin C, Viagra, etc., etc., etc. They do not help cases of fetal growth restriction. Now, there is something which is tried out and is ever rest, that is in green. You can see that does vascular epithelium growth factor gene therapy safely improve outcome in severe early onset fetal growth restriction? This work is being done and we are waiting for the result. If it gives good results, maybe we will be using vascular endothelial growth factor gene therapy in cases of fetal growth restriction. Coming to my last 3 slides, the take-home messages. When to deliver begins with the onset of intact survivability in fetal growth restricted fetuses. What to monitor is a combination of arterial and venous Doppler with input from fetal biophysical profile in compromised fetal growth restriction. How often to monitor depends on anticipated speed of clinical deterioration. Delivery is indicated when the risk for fetal acidemia and or stillbirth outweigh the likelihood of meaningful extension of pregnancy in utero. Differentiate between constitutionally small and fetal growth restriction by composite growth curves, Leica, and Doppler. Many so-called constitutionally small babies will be redefined as fetal growth restriction, adding CPR, uterine anti-Doppler, and estimated fetal weight below 3rd percentile. Doppler of umbilical artery, middle cerebral artery, and ductus venosus and aortic isthmus are useful for monitoring and timing of delivery of fetal growth restriction. Pathological growth restricted fetuses have higher morbidity and mortality rates and hence require more intensive surveillance. Thank you very much for your patient hearing.
Thank you, sir. And a word from our chairpersons.
Thank you, Dr. P.K. Saha, for your expert opinion and your experience management about the fetal growth retardation. And as we all know, fetal growth restriction is associated with long-term health problems in the form of neurovascular development, cardiovascular, and metabolic disorders. In future, is there any possibility of throwing a light to prevent these long-term complications due to fetal growth restriction?
Sir, can you repeat your question, please?
Actually,
can you repeat your question, sir?
In future, is there any possibility of regarding, you are saying that endothelial growth vascular gene therapy, is it going to prevent the long-term complications, fetal health problems like neuronal development, cardiovascular development, and metabolic disorders?
Yeah, I think the research is going on right now.
Okay, sir.
They are trying to use the vascular endothelium gene therapy in cases of suspected fetal growth restriction. They're trying to find out whether they can prevent further damage to the fetus. Whatever has happened to the fetus cannot be reversed, but you can prevent further damage to the fetus once you have picked a fetal growth restriction and you have given vascular endothelium gene therapy to these babies. We'll wait for this report to come, maybe a year or so maximum, but we will have the answer whether it is really worth using or not. But the therapy involves a lot of money. When you talk about gene therapy, I think it's a lot of money that is involved, and hence we will have to wait for the results.
Thank you very much.
Any more questions? Dr. Rekha?
So it was very crisp and comprehensive, very clear. Also, previous speakers also have given us a lot of light on the topic.
Unfortunately, I was not there.
Yeah.
Because we had a meeting of Indian Association of Gynecological Endoscopists.
I know.
was really busy with that.
Correct.
Any comment from Aruna Kumari?
Thank you, sir. It's really very excellent and brief note on management of FGR. You covered everything. No stone left unturned, sir. Thank you so much. And we had a real good discussion on algohydramnios with Dr. Sneha, madam. And we have a panel of experts. And we got one talk on prediction of IUGR also. Thank you so much, sir.
I wish
Thank you for
Dr.
joining
Sneha
us.
and Dr. Rekha all the very best.
Thank you so much.
For the elections of Foxley that are coming up.
Thank you.
Thank you
so
very
much,
much for having me with you, Sneha.
Sir,
Sir, 1 minute
always
before you-
our pleasure. So I would just say a few words about FGR. Basically, sir was given selectively the management, but as you know, sir, being a very expert sonologist, he will always speak on prediction and screening right from early pregnancy. As all of you know that once the FGR has developed, it cannot be reversed. But with your various tests, right from the clinical parameters, you can definitely predict. And if you continue to monitor, definitely you can have a optimum pregnancy outcome. That much we can have a consensus on. And sir, we are very happy and privileged to have you as a speaker. Your talks are always very, very informative and definitely practically helpful to all the obstetricians. So thank you once again. And please do keep blessing.
My pleasure.
Sir,
Thank you.
all this. Thank you once again, all the 4 societies of Andhra Pradesh, the Rajamundry, Kakinada, Eluru, and Bhimavaram. All the panelists have been wonderful, and everybody has worked very hard for the success of this program. The guests of honor, both the senior madams, they blessed us, and definitely it was pleasure to listen to their precious words as well. So thank you, Aruna Kumari, for putting up this wonderful program, and thank you, Dr. Devishri and Dr. Aruna Kumari, for all your efforts. Thank you so much for all your support. Thank you.
Thank you so much, madam. Thank you for giving this honor for us.
One minute,
And
madam.
all the best, Neha madam and Rekha madam, in your